Hey, everybody, welcome to another episode of the Exercise Mechanic Podcast. Today, we have a very special guest named Dr. Katie Dabrowski. So if you've ever been the type of person who stopped lifting because of an injury, this episode just has the potential of challenging that thinking. Dr. Katie Dabrowski, she has a doctor of physical therapy, and she's also the chief clinical operator of Old Bull Athletics. Katie, thank you so much for being here.
Yeah, I'm excited to be here. This is going to be fun.
Yeah, absolutely. Because I know at least there's definitely some big lines that we all very much agree on. And there's also some pretty niche and unique, how would I say, areas of expertise and opinions that you bring to the table that I know we're excited to explore today.
Yes.
That being said, I know that online, a lot of the content that I've seen of you, you've talked a lot about rehab. You've talked about, I would say, perhaps for lack of a better term, fitness as being a healthcare and rehabilitative powerhouse. And as much as I love all of that stuff, I've had a little bit of difficulty finding out about your origin story. And so I'd love to start there because I find that really kind of sets the tone and paints a larger picture of not just what you believe in as a clinician, but what perhaps have been some formative moments that led to where you are today and that have kind of informed your stance as a clinician. So I was hoping maybe you could kind of take us on a little bit of journey so that way myself and Ryan and our listeners could get to know you a little bit better.
For sure. Let's go on a journey. Yeah, I like it. Yes. So I did not know that I wanted to be a physical therapist, actually, even though there are so many things that make a lot of logical sense for me to have come to that conclusion well before I actually did. But I've been an athlete and involved in training my whole life. I was introduced to strength training at 14 because I was a rower and our coach in high school was amazing. And already at that time, even in the early 2000s, was very, very adamant about strength training. So I fell in love with strength training at 14. So I'm very lucky that I have now stacked 20 years of it and I'm obsessed with it. And it's something that is so just foundational to who I am. And it very much informs a lot of my decision-making as a rehab provider. So that's kind of a part of it. And, I was fortunate enough to play my sport in college, but I did have an injury that stopped me from rowing my final year. I had a disc herniation that was pretty rough. And a lot of the things I was literally just before this call doing a mentorship meeting with one of my new providers on our team, talking about how for most people, a disc herniation is like a death sentence. That's that injury that everybody is so afraid of. And there's a lot of fear wrapped around it. And also at the time that it happened to me in the mid 2010s, it was still very much of oh, this is the end. This is it. So all of those things put together, being a competitive athlete, loving lifting, and then having a career-ending injury in college would have made a lot of sense for me to be I want to be a PT, but I didn't even quite know it then. I was a neuroscience major and actually was planning on getting my neuroscience PhD because I was very involved in the research world and publication world. I worked at a lot of different labs and my focus was on actually spinal cord injury and brain injury, but more at the cellular level. So I was on big microscopes all day and hanging out with a bunch of rats. And I was doing an NIH fellowship at the Miami Project to Cure Paralysis, which is an amazing facility down here that's very cutting edge for traumatic brain injury and spinal cord injury research. And I, again, was thinking that was really what I was going to do. And every day I would walk in and past the first floor, which was this beautiful state-of-the-art gym that was run by a physical therapist who was a researcher and a clinician who was actually working with people on the stuff that I was, going down to the basement for with a huge microscope and hanging out with rats all day and kind of never seeing those studies coming to light. Bench science is super important and I loved it, but I had this kind of realization, I don't think I want to hang out with rats all day. I think I actually want to be a little bit more involved in humans. And I had this realization of oh, she's a physical therapist and she also does research and she also teaches and she sees clients and patients. Cool. That's interesting to me. So that was the first realization that I had where oh, I can kind of manipulate this degree into something that really checks all the boxes that I'm interested in. So that's what inspired me to actually go back to school. So this was kind of a in-between period after undergrad and realizing later that actually physical therapy is really of interest to me. So in a roundabout way, I ended up doing something that I think actually makes perfect sense now as a PT with my background. So I have a lot of neuroscience informed ways ways of how I work with like an orthopedic population because of my background. And then also my bias is strength. My bias is movement. My bias is challenging people enough to actually create a change in their physiology and their psychology to get better. So it's interesting that like all the pieces make, I think, a lot of logical sense for me to be a physical therapist, but I got there in a really roundabout way. And then in a really cool full circle moment, I actually teach neuroscience at the university that I went to undergrad at now and have since 2020, while also being able to be a practitioner and have a business. So I feel very lucky in that I'm kind of like wearing all of the hats that I think I ever wanted to. So yeah, that's the origin story.
Very cool. Very cool. And I'm sure that Ryan probably has a lot of follow-up questions, but I couldn't help. My mind like is a brain that like thrives off of like puns and word plays. And I find it just absolutely hilarious that you were like, I don't want to work with rats anymore. And then now you just work with gym rats, just a different kind of rat.
Exactly,
Yeah.
exactly. Yes, yes. But rats are so much easier to very confinedly control all the variables, you know? Like humans are so complex. And that's where I think the background in psychology and neuroscience that I have helps a lot, because at the end of the day, we're working with people's psychology so much. But yeah, the rats are a lot easier. They do what they do what you tell them a lot easier than humans do.
Totally. Totally. So I have a quick follow-up question, unplanned actually, but you're talking there about the complexities of working with rats and, the lack of complexity, with working with rats and the complexity of working with human beings. And I've heard a lot of people talk about this idea of in rehabilitation that you're not treating a diagnosis per se. You're not treating an injury, but rather you're treating a person.
Mm-hmm.
And I think that what that perhaps evokes, at least for me, is that, oh, well, that evokes that there's complexities to the person that's in front of us. It's not as simple necessarily as just something that's purely mechanical. And I was hoping that maybe you could just elaborate on that a little bit.
Yeah, absolutely. Something I'm very adamant about is being non-diagnosis driven. It's something that definitely informs all of my clinical decision making as well. Whereas essentially, like my job as a physical therapist is to rule out the scary stuff. And once the scary stuff is ruled out, which is very rare and very obvious, once that stuff is ruled out, it's so much more about how do I just make this human do the things that they want to be able to do? And that starts to look a lot less like, okay, this is what rotator cuff rehab looks like. This is what like shoulder labrum rehab looks like. This is what shoulder dislocation rehab looks like. It's more of like, okay, well, the shoulder has to be able to do all the same things in those scenarios anyway. So I need to just approach this from how can I make your shoulder like the best shoulder it can be? And how can I make this fun? How can I make this something where maybe we etch away at some fears that you've had over time? And how can I tie things back to your goals? Or even more importantly, your identity that you feel like you've lost because of the pain that you've been experiencing or the limitations you've been experiencing. So once we rule out the scary stuff, really the rest of it is it's fun. It's play. It's making sure that the shoulder can do what the shoulder needs to do and the rest of the body can do what it needs to do. It's making sure that, you know, part of our jobs too is to kind of etch away at maybe the harmful narratives that people are coming in the door with, the things that they expect about their pain, the past experiences they've had that have informed now how they view the world, stuff that other providers have told them, things that they read online, things that they are so convinced are wrong with them, where in reality, it's kind of reframing that and thinking more of like, well, we've rolled out the really scary stuff. The cool thing is we just get to be a bit more creative and now make sure that you can do the things that you want to do again. So I'm very non-diagnosis driven. I don't really remember the last time I've given a hyper-specific diagnosis unless it's warranted, unless there's contraindications that I need to be avoiding or things that are imperative for me to name something a little bit more. So by and large, kind of the way that I frame it, in the absence of trauma or red flags, most people's pain or discomfort is probably a little bit more to do with them asking their body to do something that they weren't quite ready for. So maybe they're not training in a way that actually relates back to their goal. Maybe they haven't done something in a long time, then they just started to do it again, so they have pain. And instead of something being wrong, it's more actionable. It's more like, well, you just weren't prepared for the thing that you asked your body to do. And we actually don't have any red flags. So that tells us really clearly, like, we don't really need a diagnosis. We just need to find the things that currently don't feel that great and create a plan to build you back up, while also finding the things that do feel great so I can keep training you and I can keep getting a good stimulus, because movement, exercise, and the stimulus of exercise is so helpful for the things that we care about. So that's where a lot of that lack of diagnosis honestly comes from. Unless it's necessary, I'm not really getting too into the weeds about it. And it's not to be dismissive of people who want to know what's going on, but framing it a little bit more qualitatively and framing it with a little bit more neutral language instead of negative language is very important. In school, we're taught to find the impairments and find the dysfunction and give somebody the laundry list of things that the first time I met you, I'm going to tell you the 17 things you suck at. Like nothing is more discouraging than that. So if we can reframe it a bit and show people like, hey, here's all like these are the things that you're a rock star at and they feel good at, we're going to keep doing that. Here's the things that you struggled with. Cool, that's data. This is information. This is all actionable. We can work on it. And then we have a really clear plan from there.
I love it. Ryan? Thanks, Katie.
Yeah, you kind of answered the question that I had about halfway through there, but you know, we don't necessarily work in the rehabilitative world, ET a little bit more than myself to the degree that you do, but I think, you know, you see this especially across maybe older generations as well, where so much of somebody's identity is tied to a diagnosis. So I think of like my parents who are in their 70s, and it's really hard to move them away from this really concrete thinking that their diagnosis is the thing that is the most important. You kind of alluded to it to a certain degree, but I'm wondering if you could expand on if you come across a client or a patient where there's some resistance to this sort of non-diagnosis treatment plan, how do you communicate to them that the diagnosis isn't as important to their treatment plan as maybe they believe it to be?
Yeah, it's a great question. And you're spot on, right? Like generationally, everybody has kind of different opinions and different views on like even the hierarchy of the medical system, right? Like I'm a PT, I'm not a physician. So there's a lot of people generationally who see me as quite a few rungs down the ladder in terms of like what my expertise is in and what my opinion is on the matter. So I want to be respectful of that too. Like it's not my job necessarily to push back and be aggressive about that stuff. Maybe when I was newer as a clinician, it would kind of piss me off. So I would be, but I think now just finding ways to communicate with people that match what they're bringing in with is helpful. For me, communication is key. I set the stage immediately with what my style is. And I set the stage early, often, repeatedly to make sure people understand kind of what our process is. So very often I just simply ask like, what's been your experience with what your diagnosis is? What have people told you about it? Just so I can get a framework of like kind of understanding how you feel about it. And then I will from there share, you know, this might look a little bit differently than some of your experiences in the past. My number one job is to keep you safe. So I'm ruling out the stuff that makes a diagnosis super, super necessary. And then otherwise, my main goal is to find the things that bother you and help create a plan to build you back to them that are safe. And then also find the stuff that feels good that I can keep progressing you on that we don't even have to worry about. So I explain that early and I explain that often. And I will also tell people, you know, there's different diagnoses or different phrases that exist that can make stuff seem pretty scary. Like piriformis syndrome sounds like you're going to die, when really it's like, you got to get your glutes a little stronger. Like that's pretty much it. So a lot of times I'll give some examples like that, where often these diagnoses are really helpful for providers to communicate with each other. And they kind of originated more to tell an insurance company what we're charging for. So a lot of times it's really just more so like we can communicate, but I want to tell you more of like the qualitative findings that I'm coming to the table with of like, these are the things that don't feel as good. These are the things that maybe you don't feel as strong at. These are the things you're having a tough time with. That's our diagnosis. Relating back to like the stuff that you are having a tough time with, that means more to us. So I try to set the stage very early, because the more I can communicate that from the beginning, the less I'm maybe having to backtrack later and help people understand like why I didn't give them a specific diagnosis that day.
I love that. I mean, at least within my work, I'm a personal trainer, and I tend to have a little bit more of a leaning towards leveraging exercise as a therapeutic intervention for folks. And so what you're talking about right now really resonates with me. And I find that setting the stage from the beginning sets expectations, but also allows the client to relax a little bit into the journey. I heard this a few years back from a gentleman who's a course provider, and he has a background in adult education. And he talked about how like adult learners want to know where they are, where they're going, and how they're going to get there. And that always landed with me, because I was like, well, as a trainer, so much of what we do is teaching. It's not just about delivering a program and, you know, being a tour guide in the gym, like, all right, here's your chest press, do your 12 reps, and do your hip thrusts over here for however many reps. There's a lot more to it. And so what you're talking about, like the importance of like setting the frame, I love that. And I'm really, really happy that you brought that forward. You mentioned on a few occasions needing to rule out, in my words, I would say ruling out the sinister. And as a trainer, we have essentially zero training in how to do that. And sometimes folks will come to us, actually quite often people will come to us, Gen Pop people who want to feel better. And a part of that, usually there's like various layers of pain reduction. And this has always been something that's actually selfishly been on my radar. And I do the best I can, but since I don't have the formal training in it, it's hard to know necessarily what to look out for. And of course, there's referring out, et cetera. But I was curious if you'd be able to maybe share some examples of some of the sinister things that fitness professionals could look out for, and that if they see maybe a few of these things showing up, that's definitely a sign that, refer out, get a second opinion. We're not just dealing with sensitivity in the system per se, but maybe there's something a little bit more going on.
Yeah, absolutely. I feel very similarly, and that it's actually a frustration of mine that the training world doesn't get as much education on that, because the trainers are the front lines of all of this stuff. You're going to see people way before a rehab provider or other practitioner ever will, and be exposed to more of the need to do this screening, honestly. That's why I created an entire course on it. Training as Healthcare is all about how trainers can feel really comfortable ruling out red flags, and then knowing that without that stuff, people are safe to exercise. And in fact, most of these people with long-term musculoskeletal pain need exercise. That is the backbone of what we are going to use to help them. I myself, I don't do manual therapy. I don't do anything other than exercise. Exercise is the modalities. I am in complete agreement that trainers and coaches absolutely need exposure to this stuff. There's joint by joint approaches for what specific red flags are at each joint. And then more broadly, the stuff that I think probably we will encounter the most is thinking of like the low back, for example. People are very, very scared anytime there is low back pain, but unless there are neurological symptoms present, or a traumatic event, or other things in somebody's past medical history like cancer that we need to screen for, low back pain is by and large not dangerous, not sinister, not necessary for a referral. But if we have things like neurological signs, like we have loss of strength, we have loss of sensitivity or change in sensation, we have radiating stuff, that's a good sign to refer out. Pain isn't necessary for referring out all the time. It's a lot more of the neurological signs that are present with it, or again, things in people's past medical history that could link back to other things that we don't want to miss. Some easy things to think of, like for the lower body, if somebody can't put any weight on their limb at all, or it's swollen, or they come into the gym and it's like dragging behind them, or they are coming in like after an acute traumatic event of some sort, like they were just playing soccer last night and somebody ran into them and they fell and now their knee is swollen up like a balloon. Those are instances to refer out. But like knee pain with squats, not an instance to refer out. So I think that goes hand in hand with imaging too. Like pain is not a clinical indicator for imaging for imaging. Neurological signs and other things that are clinical guidelines for imaging, that's when you need it. So for trainers and coaches, a big mission that I have too is to help to elevate people to feel more comfortable with managing pain, because that's the reality of being a coach. You're absolutely going to see people in pain. So the red flags or the scary stuff or the sinister stuff, they're usually tied to some sort of traumatic event or mechanism of injury, active swelling of some sort, like a gross loss of range of motion, like somebody can barely bend their knee. Inability to weight bear is a big one. And then for low back stuff or for neck stuff, neurological things, changes of sensation, changes of strength, inability to move the arm, move the leg. And then a big one for the low back too is changes in bowel and bladder function, stuff that people will know, stuff that is obvious. And I don't share those things to scare people. In fact, I share them to empower, because that stuff's rare. That stuff's obvious to rule out. The questions can be very specific and you get your information right away. And in the absence of that stuff, like people are safe to exercise and in fact need to exercise.
Love that.
Well, I have a variety of questions. I'm curious where I want to start.
Today's going to be 4 hours long, by the way.
Yeah, exactly.
This is a summit, not a podcast.
Yeah.
Cancel by 8 p.m.
This is like the extended edition of Lord of the Rings.
Yeah.
Yeah. So something that I'm curious about, we're talking about ET had used the word sensitivity, which I think is usually the appropriate word in sort of the pain context. And I think we're all in agreement here that, pain is multifactorial. And while mechanics are a component of that pain, especially when it's not acute, it's usually not the biggest component. So if you have somebody come to you, I'm going to assume generally like Gen Pop clients who are generally, let's say, sensitized.
Mm-hmm.
How much are you also, examining and addressing like the allostatic load of their life? I look at the clientele that I work with, I think very different than you two, but there's a lot of similar themes where I work essentially with physique athletes.
Mm-hmm.
And the longer that I've done this, the further and further away I've gotten, even with some of my high level competitors, from just talking about diet plans and training programs and whatever else. Oftentimes it's how can we essentially restructure elements of your life to better systematize the things that you need to do to be a good bodybuilder. So I'm curious from your clinical perspective, if you've got somebody who's coming to you who is highly sensitized, how much of the sort of allostatic load is a component of your treatment strategy?
Big time. Yeah, it's a huge part of it, I would say. And that's where, this is stuff that I think in the beginning, I probably overeducated on because I'm passionate about it, and it turned into more of like a lecture than probably a good evaluation. So I think what's interesting is over the years finding ways to integrate it, but also in a productive way and not as much of a lecture. Like, I'm a neuroscience nerd. I want to talk about this stuff all day. Most people don't. So that's where podcasts are great, because this is where we can nerd out a little bit more. But I think like knowing your audience and knowing the depth that is appropriate to go into for this stuff is huge. And that's a big part of kind of what I'm constantly navigating with people. But absolutely, the allostatic load component of it, of like all of the cup analogy of like, you can only handle so much toss. And, a lot of people that I work with are high performers, executives, people who do a lot of stuff, people whose identity is being a high performer and an overachiever. And that bleeds into their fitness and exercise too. So a lot of times the conversation is just a better balanced program to be able to help mitigate the fact that like your life is high stress. So the training style, like we shouldn't be doing RPE 9 every single training session and getting your heart rate to 180. Like that's not really conducive to adaptation, first of all. And you're just kind of like pulling from the same thread of everything else that you are doing all of the time. So trying to teach people the balance. And sometimes with a training program, it's a little bit easier to illustrate that, of showing people like how you can have high and low days, the value of more steady state work or not RPE 9 to 10 all the time. So sometimes that can be an avenue to show people that, which is really, really helpful. But absolutely, that's a huge part of our conversation. And even just integrating within like my relationship, as my relationship with people is developing. I think I used to front load the education and try to just teach people that right away, but that's really hard to do. So a lot of the conversations that I navigate just throughout my relationship with people are a lot more about that allostatic load. Like, we have tolerance of, we only have so much tolerance of the stressors in our lives, and stress is good, but it's also, we have to take into account how much of that we have, and what that looks like in terms of what you're doing outside of here in addition to in here. So these are conversations I'm weaving in a lot. It's a great opportunity too, like depending on the relationship with your client. I'm a type of provider where when appropriate, I do like to share my own experiences too, because I think it humanizes the pain experience and it humanizes how difficult this stuff is. I'm a workaholic. I'm an overachiever. I'm a high performer. I like to train really hard. I'm in that category. So I share how I navigate that. I share when I mess it up. I share when I flare. I share all of that because when appropriate, right? I'm not making it about me in the session, but I like to share that stuff because I think a big thing for people is to humanize the pain experience and to humanize the difficulty in navigating this stuff. You are not broken. Nothing is wrong with you. You are not a freak because you can't handle this. You're a human who's spiraling because this stuff is scary and because this stuff is stressful. I spiral too, even though I teach this and I have expertise in it. So I think like that's a huge part of it, of navigating that. The stress load and the allostatic model is a big component of what I'm working on with people for sure.
One thing that just comes to mind is just how ridiculous it is that even like the pursuit of a pain-free life is even possible.
Yeah.
Like people are like, oh, become pain-free with this, or bulletproof your body with this mobility protocol. And it's like,
Yeah, yeah, it's
Talk
frustrating.
about
I try to tell people like I can't prevent you from walking out the door and like not stubbing your toe on the curb. So I can't ever predict that you'll be pain free. I'm not pain free. Like I don't know anybody who is. So shifting the goalpost from I think of it my big goal with people is to help neutralize pain instead of us immediately associate as a negative thing, and to treat it as a data point that is more neutral instead of positive or negative. And that's hard, right? Like as I mentioned, I tell stories a lot of how ridiculous I am when I get a flare because I'm a human being and that's part of it. And I have the added layer of my identity is 100% wrapped up in my physical capabilities. And like same with you guys, like we have selected professions that are based on these things. So our identity is wrapped in this. So that adds a deeper layer to all of this. So I share the kind of funny stories when I know I'm being ridiculous, but it's just where my brain goes. It is so complex navigating this stuff. And even though we know we can't be pain free, even us who have expertise, when pain pops up, we freak out too. And I think just making it more of a normal conversation, people probably look at people like us and assume that because we're in this profession, we train perfectly or we do everything right or our biomechanics are perfect and we never have pain. That's just not true. So if we can shed a little light on our experiences too, I think that helps people normalize it a little bit more.
awesome. I have a question with regards to, because of your neuroscience background, I'd love to talk about one of the topics actually in the interest of transparency that you sent us prior to today. You know, and it's this idea of like the neurological underpinnings of sarcopenia and why I'm assuming power training is important. And this is something that I haven't heard anywhere. And I would really, really love to hear your thoughts on this and why power training matters so much.
Cool. Yeah, I was gonna say I love this question, but I brought it up, so
Yeah.
so that's obvious. But yes, so something I'm very passionate about is helping people understand that the doom and gloom of aging is actionable. The things that we're told, right? Like every decade after 30, you can lose 3 to 8% of your muscle mass. The stuff that's doom and gloom, like that sucks. That's scary. The great thing is though, it's actionable, and it's a lot less if we actually do train, and we have been training, and we stacked decades of training. But the good news too is it also is actionable if you start now at any age. There's really, really great evidence of not only having a long training history is obviously great, but starting literally now also impacts what our muscle mass does throughout our lifespan. Sarcopenia is loss of muscle mass that's age related. And for a very long time, we were kind of just thinking of it more from like the physical peripheral muscle perspective, like your cross-sectional area decreases, you get more fat infiltration relative to muscle mass, things that are very real and things that happen. But another really big component is actually the neurological level of loss of muscle mass throughout the lifespan. And so there's a lot of things that are happening neurologically that are existing and happening before it gets to the muscle itself. So you can have, of course, all of those physical changes to muscle, but we have to look at what's happening in the brain too, and even at the neuromuscular junction, so where the brain's telling the muscle what to do. We see quite a few things that happen with age. We see just straight up decreased cortical area for our motor cortex. So we have less real estate in the brain for the area that tells our muscles what to do. We also see a selective atrophy of type 2 muscle fibers. So we see the muscle fibers that are responsible for power and explosive work decrease preferentially over type 1 with age. So we also see decreased motor unit recruitment, or even just changes to how motor units are recruited with age as well. So we see a lot of neurological things. We see dysfunction at the neuromuscular junction as well, how we're actually, synaptically transmitting neurotransmitters to actually tell the muscles to contract. So if we think of it that way, that sheds some light on what maybe training should look like. Yes, hypertrophy and strength is super important, but what drives motor unit recruitment and neural drive the most? Power. What helps to actually really, really have a robust change? Something with a great enough intensity and stimulus to create that adaptation. So that's where power, and that's where more force production work comes into play. Like if I'm thinking of how can I if I'm thinking, for example, I have an hour to work with somebody in their 60s who's trying to make sure we maintain and build muscle. So yes, strength and hypertrophy for sure, but you better believe I'm incorporating power. Absolutely. If we know type 2 muscle fiber types are the things that go, we got to do stuff that challenges type 2 muscle fiber types. So all of this plays a big role. And if we can think about this way, again, as less of doom and gloom, but more of like, these are all linked back to very obvious actions to take. That's empowering. This is stuff that we can do. This is stuff as well. If you're listening to this and you're 20 years old, okay, cool. How do you start doing power now? So you start to really work on these neurological processes. So I think of these things, whatever age you might be hearing this information, like the time is now to start incorporating it. It's also just fun. Like there's nothing an older adult hates more than being made to feel old, especially when they're training. So if we can do things that still show people that you can have athleticism, we can have fun, we can be silly, we can do things that feel more like when you were a kid playing. A lot of that is more power. A lot of that is more jumpy, fun stuff. So that's where the neurological side of sarcopenia is so important, and I think often overlooked. And, you know, we have dual benefits here, right? Like, yes, it's helping neurologically from kind of the neuromuscular junction and neurological impact on how our muscles are working. But we also know that power and more impact work has positive impacts for bone density too. So now we're checking several boxes all at once, the things that we care the most about as we age. In an age of so much information on social media, we're actually like, people know this stuff now. I don't know about you guys, but actually for the first time in the past couple of years, I'm actually getting women coming in requesting to work on bone density and requesting to build muscle. Instead of maybe 5 years ago, I got women who just wanted to tone, who wanted to be long and lean. And now we're actually getting people coming in and saying, I know I need to work on bone density. Can we do that? That's super cool. So all of this is just helping us to actually really help the negative downward spiral that I think people think aging is, and we can make it a little bit more actionable and maybe slightly less negative.
Very cool. Go ahead, Ray.
So I think something that's really fascinating, and again, you had kind of alluded to it when you were just talking about what your history was, of getting into your field. I think many of us, come from athletic backgrounds, and that's kind of what propels us into the sort of our chosen fields. I know for myself, and it sounds like for yourself as well, much of your philosophy is kind of informed by your athletic background. And I'm curious, I don't know all the populations that you work with, but I'm curious, what lessons do you think your Gen Pop patients can take from athletic populations and vice versa?
Yeah, that's a good question. Yeah, I would say my population is like weekend warriors, people probably who maybe were high school and college athletes and kind of wanted to stay active for a long time. I definitely get people who are not as active and didn't have as much of an athletic background either. But I would say like Gen Pop, like us, like it's like people like us, people who we still have it. We still want to feel something, and it's really fun. It's a super fun population. And I would say like, good training is the same for everybody. Everybody needs exposure. Everybody needs more muscle mass. Everybody needs more strength. Everybody needs more power, more explosiveness, more tendon stiffness. Everybody needs a better cardiovascular system. Everybody needs the ability to sprint or do something with high intent for a short burst of time. Everybody needs the ability to sustain activity for longer times. Everybody needs to be able to tolerate impact and also produce force. Everybody needs all of it. So I think that full spectrum is what everybody should take from training and find ways to, of course, fit it within the confines of what's available to somebody and what somebody has access to. It doesn't have to look the same for everybody, but I think the lessons from being an athlete absolutely translate to the lessons of just being a human. Like we have to all have access to these things. It just might, we might titrate the dose a little bit depending on who it is, or it might look a little bit different. Like if we have people who aren't sprinting necessarily, like you can get on an air bike and push it pretty hard. So we have to have all of these features, I think, to just be a human. Yes, being an athlete informs my decision making, but also understanding, I think, the components of athleticism that I firmly believe should be available to every human is really what informs my decision with training.
I love that. This reminds me of the importance of generalization when it comes to athletic development, especially with kids. I know this is a very different subject, but if we're thinking of being a rock star was something ultra specific. We get what would be we get diminishing returns the more you start to like really specialize from a really young age, in contrast to like go broad, go wide, which exposes the body to various stressors. And I can only imagine promotes just greater generalization and perhaps greater resilience, like a more well-rounded human. And then by extension, if you can be very well-rounded as a human, then thus perhaps, you'll be able to push that much harder when you choose to specialize.
Yeah, that's David Epstein range 100%, right? Like that great book. If people have not read that, it's all about, actually being like kind of a jack of all trades, master of none. And we see that in the literature for early specialization in youth sports for sure. People are more successful when they're exposed to a broader range of things. And I think of it as I do with most things neurologically for sure. You're just giving your brain, your body more options. I think of it as, and the phrase is used a lot, like movement abundance. Like I want to give people an abundance of options for how they move. I want them to have their patterns of preference that when you're stressed, fatigued, that your body's going to default to. Everybody has those. I don't want to diminish those. I don't want to think that's pathological. That's actually a good thing. You need something that your body will go to when fatigue is high or stress is high. But you also need to level up the stuff that you're not as good at. So you have options, you have abundance, you have the ability to, based on what stressors are presented, you can kind of toggle back and forth with all of the things that your body can do. The example I always give is like, I'm a very hip dominant athlete, like hingy, my glute and my hamstring strength is my power. My quads relative to my glutes and my hamstrings are nowhere near as strong, and I'm not as comfortable in like very upright quaddy positions. I don't want to stop training my hip dominant positions because that's where I am a badass. First of all, it's fun. My identity is wrapped in my strength. So don't take that away from me. That's what I'm good at. I want to keep it. And then third, that's where my body will go when fatigue is high. If I'm going to max out, it's going to be hip dominant. But I also need to make sure I level up the stuff that I'm not as successful at. So I just have options and I don't run out of the one strength that I have or the one option that I have. So that's what also informs a lot of my decision making too, of like, I'm not going to only give somebody the things that they suck at because it's not going to be fun. And I'm also going to detrain their stuff that they're really good at and that they need to stay good at. So that really, really informs what I'm doing and makes sure that I'm trying to keep people as well-rounded as possible.
That's really great. One thing so I'm sold on the importance of power. Ryan, I don't know about you. I'm sold on it. But let's say there's folks that are listening that are like, what does this mean? We understand that maybe for lower body stuff, you could do like jumpy things and sprinty things. Mm-hmm. But what do we do when it comes to exercises that are more power focused in the upper extremity? For those that are listening that maybe don't have any ideas, what might be some examples to make this concrete for them?
Yeah, absolutely. I think in general too, right? We can almost go, before I fully answer that, just generally speaking, we can almost, when we think of power, sometimes think that means like, what do you mean? I got to get like Susan, who's 74, to do a broad jump? Are you kidding? Like, it doesn't have to be a super explosive plyometric. It doesn't have to be this like crazy, crazy thing. Doing something a little faster than they normally do is power. Standing up really fast from a box squat is power. So you can think of like, first and foremost, just do stuff faster. Cool. That's a great way to integrate more power in your training with people. Another thought for the upper body, because it's like a little bit easier to conceptualize sprinting and jumping for the lower body, but we can do plyos for the upper body too. A great thing that's accessible to most people, med ball tosses. That's really fun too. And you can manipulate, there's like infinite degrees of freedom for what you can do with a med ball. There's just so many opportunities and things that you can do. Plyo push-ups, even against a wall, like that's power. Moving stuff faster, again, that's power, absolutely. Fast, like planks, fast shoulder taps, that's power. That's a little bit more impact. That's something different than just slow and steady strength training. So there's a lot of ways to even start just baseline with anybody who maybe you don't feel comfortable with jumping yet or throwing a med ball. Just make them do stuff a little bit faster than they typically do. And you're already starting to train that system differently.
Beautiful. Thank you.
So this question is a little bit selfish. We're talking
like asking for a friend.
Yeah, asking for a friend, bearded friend. So, we're talking about kind of this role of neuroscience and in a way sport development as well. We were kind of discussing with this. So Very unsurprisingly, I'm a stereotypical Canadian where I basically played hockey for 20 years, now a competitive bodybuilder. So I've essentially, for the last 10 years or so, been exclusively like a sagittal plane athlete.
Mm-hmm.
And to anybody who's a friend of mine, I've probably been annoying as I've been rediscovering some of my passion for hockey. But I'm curious from your perspective. So when we're looking at the effects of what I'll say like high skill movement, what are the effects of like these high skill movements, kind of doing things that are awkward, that we have to be reactionary, etc.?
Mm-hmm.
Like what effect does that have potentially on brain development, cognitive development, so on and so forth? So even something as simple, ET knows me really well. When I commit to something, I become the biggest nerd ever about it. So I literally ordered these balls that are the same weight as a puck. And I have in my schedule over here, I have 10 minutes of stick handling time a day. And I just stick handle around my house and practice stuff. And there's this moment where, I played for 20 years where this was completely second nature. And I am consciously thinking about this act. And it's almost been this really abrupt confrontation with like, oh, this is a skill degradation that I'm trying to relearn. So I'm curious if you have any thoughts on, maybe these like exposure to skill type movements and the effect on the brain.
Yeah, absolutely. So I think of it in a few ways. Skill development, as you can see, it degrades. So keeping up the skill component of things is very, very important. And as we get older, you start to realize that, like, when's the last time you learned a new skill? Like, it's very often that we don't really. That's why I think like BJJ becomes really popular. 30s to 50s, everybody's obsessed with BJJ. I think a lot of it's community and it's really fun. It's also like, when's probably the last time you've learned a skill again, especially a movement skill, that then you can see week over week improving. That's awesome. I think it's amazing for that reason. So I absolutely integrate with everybody some form of movement that you're learning that has a new skill to make sure that we're stimulating that stuff too, because it's so important. And, anytime we add a cognitive element, so something reactionary or something where you have to think a little bit more and plan ahead, spatial navigation, like any of those components of executive function, so really high level brain stuff, like up in the cortex, we get more context that then therefore allows longer term like memory of the skill, for example. So to not go too in the weeds, if we think of like short term,
for sure.
Okay, this is the neuroscience lecture nobody asked for. So we have short term memory and long term memory. And this is a sweeping oversimplification. So any neuroscientists out there, don't come at me. Short term memory is something that stays a little bit more in like the hippocampal loop. So it's staying within your hippocampus. And to make something long term memory, we have to have context that helps it get to the cortex and make it stick. So if we have things that provide that context, these skills last a little bit longer, they have some meat behind them that actually make us have a better access to it up in the cortex in our executive function areas. Again, that's a huge generalization of the process, but that's some components of it that we can think of. So if we want something to actually stick and last, we want to create a context that makes it stay in our cortex. So that's one way to think of it, why this stuff is really, really helpful and important. Another thing, like, we talk about like motor learning a lot. Motor learning is basically just the ability of the motor cortex of your brain, just like I was talking about, to actually have something that is profound enough of a stimulus to make it last and make it stick. And we don't really get motor learning unless we make errors. So the brain's ability to learn to judge an error and then correct is really what makes motor learning occur. Otherwise, you're just like practicing something and kind of doing it in a way that your coach told you, and maybe getting a lot of cues that don't even let you make an error. So you're not actually having to go through the neurological and cognitive process of error identification and then correction. And I'm always careful when I say error, right? Because I don't want it to be misconstrued as like there's a right or a wrong way to move. It's more of efficient or less efficient ways to achieve a goal. So for you with hockey, for example, like there's a better way to work on your skill versus others. There's ways that you will get the outcome you want versus not. And like your brain needs to make those errors or mistakes to then be able to combat them. So that's a really important part of coaching. And that's why external cueing is really helpful. That's why not over cueing verbally is really helpful. It's why not creating only a perfect laboratory setting in the gym is helpful. We see this happen a lot with training jumping, where people get really in the weeds of like, when you land, you got to stick the landing and be perfect and be in this position. And when have you ever seen somebody in sport land and stick the landing? They're met by a series of stutter steps after and collisions with the ground after and somebody else running up and hitting them. So if we create this perfect scenario and expect this perfect scenario in a laboratory-like setting, we're actually not really getting motor learning either. So that all comes to play with, it comes back to creating context and making your brain learn how to make a decision and shift from one strategy to another based on errors and based on learning actually what is most helpful for the goal activity that you're trying to do.
That's amazing. Thank you. It reminds me a lot of, I don't know if you're familiar with Sue Falsoni. She used to work for the Dodgers. Yeah. And I think I saw her in a conference maybe a decade ago. And
yeah,
just
I have her
one
book
phrase,
for sure. Yeah.
Perfect. The one phrase of just giving people movement options is something that's always stuck with me. And it sounds a lot like that's kind of what you're getting into the weeds to discussing there.
Absolutely. Yeah. And I think too, like, now if we bring it all back to, we know sarcopenia is neurologically mediated. You better believe I want to do things that are really working on like neurological skill development too. Like if we know that cortical area decreases, like motor cortex area, the real estate of the brain for what tells your muscles what to do. We know that decreases with age if we're untrained. Then I need to do things that are cortically driven, right? I need to do things that tie back to how can I make this actually change this person's brain to take up more real estate for motor skill development and for motor learning and for movement acquisition, all of that stuff. So that's another, it just all comes back to, like, it's all neurological at the end of the day. It all comes back to how can I make this have more of a lasting imprint into somebody's brain so it doesn't detrain over time. That's really, like, if we tie it back to that, that can also keep us, I think, on our toes when we're training people too. Like, that to me makes sure that I'm never mailing it in a session. If I really think this is so important neurologically to make somebody healthier their entire life, there's no possible way for me to give somebody like a bullshit exercise. There's no way. I'm going to be very focused on making sure I'm giving them the best exercise I possibly can. And I don't even mean exercise, I mean stimulus, because exercise selection matters a little bit less here, but more of like the stimulus that's going to neurologically change them. Then, like, I'm going to give them a rock star session every time, and it's going to keep me really, really on my toes as a provider too.
I have one I apologize, T. I have a follow-up question. You actually teed me up perfectly for this. When I was just going through your social media, there was one, I'm forgetting specifically the discussion that was had, but essentially discussing like dementia. Mm-hmm. So I think most of us know, number one, like dementia is obviously a risk as people are aging. We know that exercise is heavily involved in potentially delaying or offsetting some of the symptoms of dementia. If you had to assess kind of like a hierarchy of need from I guess like physical and maybe neurological stimuli, things that you would do as a practitioner, you've talked about power output, obviously building muscle mass, some of these skill-based movements. What would maybe your hierarchy of, I'll loosely say exercise or stimulus that you want to provide to your patients?
Yeah, I think a great way to just like simplify, because it also relates so much back to cognitive and neurological health too. How can I make somebody's metabolic health as optimal as possible? And with that, I need a lot of muscle mass. I need a good cardiovascular system. I need less fatty infiltration and more muscle actually in their muscle. And then also, like, if you want to add to the cognitive side of it too, we need fun. We need something to be fun. We need community. We need laughter. We need socialization. We need all of that stuff. So I think, like, and that's makes it sound probably obviously simpler than it is. But if we hold ourselves to a standard of within this hour that I have with somebody, or however much time I have with somebody, if I'm thinking of all of these things, if I'm thinking of brain health, if I'm thinking of long-term health, making sure that somebody is independent as long as possible with their lifespan, That's really what matters. We need to create a space that somebody can have fun in and have a community that they look forward to seeing, that they have laughter and that it's enjoyable and it's positive. So that's a huge part of it. And then we also need to do things that are really helping somebody's metabolic health improve. There's so much overlap in neurological conditions and poor metabolic health. And when I say metabolic health too, I just think umbrella terms of things like obesity, being overweight, metabolic syndrome, diabetes. So all of that stuff is very, very, very linked to cognitive issues and neurological issues. And it's for a lot of reasons. A big reason is on the pathophysiology side of it, of like literally just that fat is more of like a pro-inflammatory molecule, and all of the downstream effects of just having more things in your body that increase and inflammatory processes. And I don't mean like buzzword inflammation. I mean neurological changes and changes in how your body processes blood sugar and changes in how your body utilizes the food that you eat as fuel to complete activities and exist as a human. That's what I'm getting at. Not that we need like a skinny tea detox. So if we have more fat accumulation relative to muscle mass from a pathophysiological perspective, we have more pro-inflammation going on. And that has a lot of downstream effects. Then if we also think of what that looks like more like physically, if a muscle is supposed to contract and now you have more tissue that doesn't contract where that muscle once was, it's probably not going to be as strong. It's not probably, it's definitely not going to be as strong. So what we see in people with poor metabolic health, we see more fat mass relative to muscle mass. We see fatty infiltration in muscle cells. We also see connective tissue deposition, so more non-contracting stuff in muscle fibers and muscle bundles and fascicles than just the muscles themselves. So we can already therefore assume, and not even assume, it's just is what it is. These muscles are not going to be as strong. They're not going to distribute force as well. They're not going to produce force as well. So then you can have tendinopathies, you can have joint issues, you can have more musculoskeletal pain that then adds to more sedentary behavior, which is also a precursor of cognitive decline. So it's all inextricably linked. I need to get people jacked. I need to give people a good cardiovascular system. I need to make them laugh. I need to make them have fun, and I need to make them learn skills. If you do that over and over and over again, you're helping all of this stuff.
I mean, talk about a masterclass on not just rehabilitation, which is kind of very much how we started today. But here we're just talking about like building robust and healthy humans, and that in doing so, it's very much like the rising tide that lifts all ships. Where as we start to do these things, we improve metabolic health. We see, generally speaking, self-efficacy increase. We see pain go down. We'll see cognitive health improve. This has been really, really awesome. I was going to tee you up to talk about the metabolic health and the pain side of things, because I know that's something you're kind of like jazzed about. But maybe we could just kind of double click on this, because this is something that truly is very rarely a part of the conversation. And so I'd love to like flesh this out and make it really clear.
Yeah, absolutely. Yeah, it's very interesting that we're just getting more of the conversation and more literature on the relationship between a lot of chronic musculoskeletal pain, like the aches and pains that we see a lot of, like tendinopathies, osteoarthritis, and osteopenia, osteoporosis, like the stuff that we as providers, as coaches, as trainers, as rehab providers, we're going to see the most of. We see a huge relationship in individuals who experience that alongside individuals who have poor metabolic health. So a lot more research now is being done on kind of the concurrent inflammatory pathways that we see with both of those conditions. And actually, like I was mentioning before, more fat, just having more fat molecules and all of that is related to just like an increased inflammatory system, essentially. So that's a huge part of it. But yes, we like the very interesting stuff that we're seeing now is individuals who have kind of chronic musculoskeletal conditions. We're seeing that it's a lot more related to their lack of muscle mass relative to fat mass. So they're under-muscled and having too much fat mass. Their poor cardiovascular health, instead of it being like, oh, you have a tendon problem, it's like you have a systemic problem that's therefore relating to a poorer quality of your tendon. So if we have tendons and muscles that are supposed to have contracting fibers, and as I mentioned earlier, we have more fat mass and more connective tissue instead, we're actually seeing that the quality of people's tissues is poorer in those who have poor metabolic health. So if I only treat your tendon, I'm missing the mark. If I only treat your osteoarthritis, I'm missing the mark. If I only care about the diagnosis, then I'm completely missing the systemic issue that is going on. So that's where my argument that I talk a lot about, and it's like in my training as healthcare course too, trainers and coaches, they need to know this stuff, because the ability to just improve general metabolic health is going to have bigger, often downstream effects for their chronic musculoskeletal pain than only zooming in on their tendon. So somebody who has obesity and who has diabetes or metabolic syndrome, who has patellar tendinopathy, if I only do isos for their knee, which is a great strategy for tendinopathy, I'm missing the fact that they are undermuscled, their cardiovascular health is poor, and they systemically have issues that are therefore causing their tendons to not be as high quality. So it's really, really important to take this into consideration when we're trying to develop a treatment plan for somebody. It's why, this stuff I consider to be non-negotiables for when I'm talking to people about their issues that they're coming in with, because I'm not only going to zoom in on their tendon. I care about what cardio they're doing. I care about building them a program to do more cardio. I care about, in general, giving them more muscle. So it might look confusing to somebody of well, I'm here for my knee. Why do you care about what I lift for my upper body? Because I need to know that you're doing enough to actually build muscle, because that's going to help systemically solve some of this problem. So what's cool about it too is it's low-hanging fruit. Every single person who is a trainer or a coach or a rehab provider, movement is all of our scopes of practice. There's nothing in there that makes it so only I can work with this person as a PT. So it opens and broadens our scopes, and I think levels the playing field a bit more, so we can work together to work on this bigger picture, physical inactivity crisis. In America, less than 25% of people meet physical activity guidelines, which is just twice a week of strength training and 150 minutes of activity during the week. So I would venture to say it's a lot less that we have tendon problems, and it's a lot more that we have metabolic systemic health problems. And if we don't ever address that, we're missing the mark big time.
Man, Brian, I think I gotta punch you through the screen so I can get my questions out here. Go ahead, man. I got so much to say, but go for it.
So something that really stands out when I'm listening to kind of discuss, both the theoretical as well as the practical application of, the work that you do, I think that really good practitioners do a great job identifying bottlenecks. And you had talked about, something that maybe younger trainers or practitioners maybe struggle with. They zoom in on, there's this one tendon issue, et cetera. I certainly see this a lot in the training world where, in a really positive way, trainers are more and more valuing education. There are so many course providers. So they take a whole bunch of courses, but what happens is they get this massive philosophical shift every single time they take a course, as opposed to having kind of a philosophical framework that they take these courses and it informs some of their sort of identification skills, some of their underlying principles, and then using that framework to then properly identify and then address some of these bottlenecks. So I don't know if this is something that, it sounds like the way that you're talking about this, that you have kind of a framework that you're using to be able to identify these problems. I don't know if you can speak on that a little bit more, or maybe to some of the younger practitioners and trainers, any advice that you might have on, not missing the forest through the trees, learning how to develop kind of a system that you can actually address the individual in front of you and not get stuck looking at these problems that are maybe low returned.
Oh, a big framework gal, absolutely. Yes. Yes. So I absolutely, yeah, I like frameworks rather than systems, right? Because systems put us in boxes and no human is a textbook. There's no human that I've ever met who checks every box in a certain system. We can take a lot of stuff from systems, and I think that's why education is great. But you're right. We're very often like, you take that one course and you're like, this is now my identity and this is the type of provider I am. And then you take another course and you're like, oh God, here we go again. This is now it. You're like constant existential crises over and over again. So I think of it very simply, and then I can kind of go a little bit more specific. Very simply, the question I ask myself when I'm thinking of an intervention for somebody: does this positively impact their physiology, and does this positively impact their psychology? Those are the two first most general things that I have to make sure I'm addressing every single time. So am I doing enough with this person to actually create a physiological adaptation? That's where rehab usually goes wrong. Usually we are way underdosed, and the actual exercise intervention that we are giving by no means changes physiology at all. So that's usually a big problem. And then on the other side of that, from a psychological perspective, am I doing anything that's maybe instilling a narrative that could increase fear around movement, that could make somebody more hesitant, that could give somebody a negative experience with movement that over time will inform their life over and over again because they left me telling them that they're broken, they're fragile, something's wrong with them. So that's the main thing that I care the most about. And it's very general, and I realize that. But I think those are easy things to ask yourself time and time again. Am I making somebody psychologically more resilient, more positive? And then am I also actually doing enough to make their physiology change? If the answer is no, it's not for me. So that makes it very easy in deciding how I want to work with people and the things that I choose to work on with people. So that's a big part of it. Another thing that I love is patterns. So pattern recognition is so valuable for trying to identify, with all of the information somebody is giving you, maybe what's related to their pain or maybe what's related to the issues or the limitations that they're experiencing. So I'm looking for patterns in the story that people tell me. The first big pattern I look at, and I'm not necessarily telling people these things, but I'm thinking of it in my head, is this person like a catastrophizer or a confronter when it comes to their pain? Do they freak out at any instance of pain and think they're dying and spiral? Or do they confront it and maybe keep training? Or maybe even on the farther end of the spectrum, do they just not listen and send it and overtrain? That gives me a lot of information. Yeah, hands up for that one. Yeah, that gives me a lot of information of how I need to talk to this person. Because if I have somebody who never wants to be told to do less, if I come in and tell them to do less, they're going to hate me and they're not going to listen. If I have somebody who feels that way and I instead say, I'd really like to find a way to optimize your program so it really makes sure you're getting your goals, that's very different. In my head, it's absolutely, I'm going to be telling them to do less, but I'm optimizing. So language matters. If I have somebody who's a catastrophizer, I need to be mindful of how I speak about this stuff too. If there's somebody with low back pain and I'm like, don't worry, we're going to get you to deadlift. All they hear was this meathead did not listen to me and I'm scared and I never want to deadlift. And my doctor told me I should never bend over with weight. So that really matters. Do they catastrophize or do they confront? Another thing, are they an overdoer or an underdoer? If they're an underdoer, they're somebody who's probably not meeting PA guidelines, probably maybe more on that poor metabolic health end of the spectrum, probably not training at all or in a way that matches the demand of what they have to get back to. That's important information. On the other end of the spectrum, are they like us? Are they overdoers? Are they constantly doing everything? Do they do CrossFit and yoga and train for an ultra and they just signed up for High Rocks? And do they do all of these things over and over again? That also changes how I'm going to talk to this person. Another thing that I look at from a pattern perspective, what are the buckets that are being filled in their training or their activity versus not? So are they a powerlifter who basically does the big three, and a lot of their accessories are still very sagittal plane based, probably still bilateral, not a lot of exposure to different planes of motion, not a lot of exposure to different contraction styles, to different rep ranges? Are they a CrossFitter where they do a lot of high intensity stuff for time, and a pattern in CrossFit is a lot less eccentric control because they got to do shit fast? Cool, that's information. So what type of training do they do? What buckets are filled versus what buckets are not filled? those patterns give me so much more information than a diagnosis. Those patterns give me so much more information than a biomechanical movement analysis. So I think if you can start to find some of that stuff, it helps a lot. It also makes your questions more laser focused because it's easy to get lost when you're asking questions. So that stuff is really, really key in how I navigate those scenarios.
That's awesome. I think there's a lot of what you're mentioning that brings a lot to the forefront. But one of the things that I have in my mind currently, because I feel like over the last 10 minutes, I've had like 30 different prompts. I'm like, oh, I got to say this. And I'm like, oh, fuck, no, wait a minute. There's something else. So anyways, I'm on prompt 31 right now in my mind. And the one that I have currently in my mind is just how the more, at least for me, and it seems like you're saying something very similar, that like training in rehab, it's essentially same thing. We're talking about a continuum, and it really just boils down to dosage. And and I don't know if you would agree with that, but it seems very much like that's kind of that you said that directly and indirectly in a lot of things that we've talked about today, which then brings to the forefront the importance of load management, and then kind of connects to this larger kind of overarching movement optimism movement that's been happening in the fitness industry, which I think is maybe one of the best things that's happened in the training industry, at least in my opinion, maybe ever, because for a variety of reasons. But I also think that as a part of this conversation, it's also important to maybe ask ourselves, like, what are the limits of adaptability? Like, people talk about how, like, yes, you can like just expose the body gradually and you can adapt and you can adapt and you can adapt. And I think that that's a really fantastic question to ask, and for something to kind of, for fitness professionals and rehab professionals to grapple with. But I also wonder, when should we not do that? Like, when should we not leverage graded exposure?
It's a great question.
When it comes to desensitizing people. So I'm kind of curious how you work through that.
Yeah. So first of all, yes, I 1000% agree that training and rehab are the same. It's why my course is called Training is Healthcare. It's why the model that I have set up at Old Bull, my facility, we have 3 locations in Miami with just the best team ever of all dual credentialed rehab providers and strength coaches. And my goal is when people walk in that they would not know who is there doing training or rehab. That's how much I believe they're the same thing. Like, you should walk in and have no idea who's doing what. And if, creating an adaptation for change is the hallmark of resistance training, it just always blew my mind that wasn't for rehab, because you have somebody who needs change the most. Like, you have an injury, you have something you need to build back from. Why are we not progressively overloading or graded exposure with that? Like, it just blew my mind. So that's really like why our model exists the way that it does. So yes, but then on the other end of the spectrum too, like, graded exposure isn't necessarily maybe always the perfect answer. And I think of it more maybe in the case of like very acute sensitivity. So, I'm a meathead. Like, my bias is strength. Like, I want a graded exposure to everybody and I want to just build. But when you have people who are highly sensitive and very acutely flared up, sometimes that doesn't necessarily work. Or in real time in that first session, for example, like if you're trying to kind of build somebody back up. So there's a lot of things where if somebody's so acutely flared, like just to prove a point that, somebody with an acute low back pain, for example, and it's very acutely angry, like all positions are intolerable. They have a lot of fear. We've all experienced those type of acute injuries where even us as movement professionals, we know like movement is not going to make me feel better right now. Like, I hurt everywhere. I'm sensitive to everything. So that's where, just to prove a point that deadlifting is safe for this person, that's probably not going to be my main goal immediately with them. It's probably actually going to be a bit more on the education side. It's probably actually going to be a bit more on the general things that in their day-to-day life, I can help them tolerate a little bit more. And sometimes it's calming shit down, not only jumping to building shit up. Like, that's an important thing. So that's where I think the argument can get tricky, because that's where I think like manual therapy comes into play for a lot of people's brains of like, well, this is how I'm going to calm stuff down. And somebody like as myself, where I don't do manual therapy, I like to think of it more. I still want to create the like neurological context of not relying on something like a passive modality, and still trying to find ways to do other things that are a bit more active still, that again, maybe aren't focusing on building somebody up, but just calming things down with movement or with breathing or with activities that they enjoy. If I have somebody with a very acute low back flare and everything hurts them, but they can tolerate maybe walking for a few minutes even, like a big strategy that I'll often use is like, forget about fitness right now. We're not building your fitness right now. We're not building you up. We're not like progressively overloading you. We're trying to utilize what we know about physiology to help you feel a little bit better and calm down. So we know that blood flow and circulation helps stuff calm down. We know that. So if I can find ways to get a little bit of that, we're going to do that. It might be walking. It might be 5 minutes at a time, but that's kind of the lens that I try to talk through these things with people where, yes, I want to get to a point where it's about progressive overload, but sometimes it's not yet. Sometimes it's just calming you down. Sometimes it's letting physiology help you and not only trying to build your physiology back up. So I'm working with a pretty acute low back disc herniation right now, fully virtually, and he's a very active dude. And we have to have this conversation a lot where he even said, like, these exercises aren't hard enough. And I'm like, good, they're not supposed to be. They're literally just ways for you to move so your like head doesn't explode from sitting around all day, not being able to move. And so we can start to actually give you some like circulation and blood flow. That's it. So trying to encourage people to sometimes remove that need of like, is this building fitness? Am I getting resilient? Am I training? Is this trainable? Sometimes it's not. Sometimes it's just to calm you down, and that's okay too.
I love it. We're going to be getting to some rapid fire momentarily-ish. But before we do, I have one more question that I'd really love to tee you up on, because once again, when we communicated a little bit by email prior to today, you mentioned something that I had never heard of. And I'm grateful that you brought it up because I Googled the snot out of it because I have a cold right now. And I would love to just kind of hear more about, generally speaking, what this concept is and also how you've integrated it at Old Bull. And it's this concept of unreasonable hospitality. I find this really fascinating, and I'd love for you to talk about maybe what it is and why it's so powerful.
Absolutely. So I'm sure in your Google, the book entitled that came up. Unreasonable Hospitality is a great book. It's actually written from the perspective of taking a restaurant that was struggling to basically become the #1 restaurant in the world. But it's an amazing book, and I highly recommend anybody in a service-facing, client-facing industry, which is all of us, to read it because there's so many parallels, and it's much more about how you can have a really exceptional service delivery for any person that you work with. And so the concept of unreasonable hospitality is basically providing an experience that is so exceptional that people cannot even believe it exists. So I say that with healthcare at Old Bull, we're trying to violate any expectation somebody has with healthcare. We're trying to completely disrupt any expectation somebody has about pain, injury, movements being dangerous, whatever they might be, the second they walk in our door. And we're doing that a few ways. First of all, we're thinking in terms of being basically like obsessively curious about the person in front of us. What makes them tick? What is their identity? What are the things that actually like underlying all of the reasons they think they came in for? People think they come in for pain. It's not for pain. There's something that is so close to their identity that they feel that they have lost because of their pain. And I need to find that out. So that's really what this is all about. Like, how can I intimately get to know the human being in front of me and provide an experience that is so tailored to them, that is so unreasonably exceptional that they can't even believe that they're getting it. And that's really that's what makes me so excited about the work that I get to do, because if we can really feel that way about what we do, man, it makes even our hardest days so much better. Like, I want to provide an experience that people didn't know they could get when they are experiencing pain. I want to provide an atmosphere that is so fun and so welcoming that they don't walk into our gym and see squat racks everywhere and see, our team lifting, doing crazy things and feel like they don't belong. I want them to actually realize like, oh, I do belong here. This is fun. I thought gyms were like bros who kind of look down on me because I don't train. Like, I thought gyms were only for people who were really fit. I thought gyms were not for me. I want to create an experience that makes people realize that that could not be farther from the truth. So unreasonable hospitality is, how can you just like violate the expectation somebody has about what they really expect to get out of meeting with you? How can you be so understanding and open-minded and there for them in a way that like they didn't even know a healthcare provider? I consider absolutely trainers and coaches as healthcare providers too. When I say that term, it's all of us. How can you be a healthcare provider that just goes against any idea of what they ever had in the first place? That's how I think we combat burnout too. That's how I think we really, really keep like the love for what we do. I think also the reality is sometimes too, as I think this happens a lot as trainers and coaches, and I know it happens as PTs too. Like a lot of times people look at PTs like, oh, did you just not want to be a doctor? Like, is this why you're doing this? And a lot of times people look at trainers like, oh, you didn't want to be a physio. And there can be these moments in our lives where we're like, am I just hanging out in a gym all day? Like, what am I doing with my life? Like, we can all feel that way. And when you flip that on its head and realize that you're providing a life-changing experience to the human being in front of you, our jobs are so cool and so valuable and so important. And I think it really solidifies that if we can think of it from that perspective.
Amazing. I mean, I think, well, like I said, we'll get to the rapid fire thing here, but I mean, you just put your finger on exactly why I do what I do. You just put your finger on why the Exercise Mechanic Educational Initiative exists. It's for this very reason, like to passionately serve fitness professionals because of the power of the medium. And so I love your answer with a capital L, and talk about a really great way. We talk about like just being insatiably curious about the person in front of you. What an amazing way to create trust. And then by extension, strengthening the therapeutic alliance and driving adherence. Like that's massive, absolutely massive.
Yeah, it self-corrects for the problems that I think most people say that they have, adherence or buy-in or things like that. All that goes away when you make it very obvious that you just care. Like that's it. Buy-in, all of that. It's easy to achieve. And I hate to say easy, but it is if you really think of it from that perspective. If you make somebody feel heard and understood and that you care about them, the buy-in's there. It's not something you have to fight for.
Beautiful. Ryan, why don't you take us away for our rapid fire, man?
All right. So as
Buckle
ET
up,
said,
Katie.
Yeah. So we do a little rapid fire with any of our new guests. No long-winded answers. So first thing that pops in the top of your head. Ready? All right. Our first question is, what is your favorite book, movie, and concert?
Oh my gosh. Okay. Book, movie, and concert. My favorite book this is kind of depressing, The Bell Jar by Sylvia Plath. It's a very dark book, but I like it. Movie is, oh my God. This is difficult. I don't think this way. Okay. My favorite movie, I'm going to go funny for this. Wedding Crashers, 10 out of 10, solid humor. And then my favorite concert, this is also very difficult. I think Florence and the Machine in New York City was pretty amazing. Yeah.
See, I think we're pushing up against some of your patterns. Now you have to make errors and be more efficient in your answers.
Oh my gosh, you're right. You're right.
Favorite and least favorite food?
Favorite food, cheese. I love cheese.
That's every woman ever.
I know. It's in my bloodstream at this point. Least favorite, I don't eat meat. So meat which is weird because I like cheese. So meat grosses me out. Least favorite.
Proudest moment outside of business?
Proudest moment outside of business. Oh my God. Outside of business. This is really hard. I'm taking off my glasses. I'm sweating. Proudest moment outside of business. I think probably coming back from my disc herniation. I think actually.
Favorite athlete growing up?
Michelle Kwan. I wanted to be a figure skater so bad, even though I lived in Florida and cannot figure skate.
What 3 values guide you?
Okay, that's like not rapid fire. 3 values: integrity, passion.
Favorite and least favorite lift?
Favorite lifts:
It's hingy
barbell
for
reverse
sure.
barbell reverse lunge or
Right.
kickstand deadlift. Least favorite bench.
Same. One misconception about you?
Maybe, I don't know. Maybe people might think I'm intimidating because of a lot of the stuff that I do, but I'm just a weirdo and I'm pretty chill.
One region that you would love to visit.
I have not explored Asia yet, so I would like to visit Asia.
All right. And our final question is, what's one hard truth that personal trainers or coaches who are trying to build their businesses needs to hear?
Sometimes it's going to be really, really hard and you got to work a very long day and get over it.
I think that answer and some variation of that answer is what almost every single guest has said. Pretty
really?
damn close.
Oh, yeah. Across the board, it's our most common one.
Interesting.
Yeah.
How many people have said cheese is their favorite food?
My fiance, first of all.
She sounds like a great gal. Yeah.
Well, speaking of,
I don't think anybody else.
No one else has said it. But speaking of cheese, you should go to Switzerland. It's the land of the cheese.
I have been twice. Yes, I love cheese. Yeah, love cheese, love Switzerland. I've been. Oh yeah.
Amazing.
Yeah.
Honestly, I could talk to you for hours.
This is super fun. Yeah.
I find that it's one of your strengths, one of your many strengths, just based off of this initial conversation that we've had, is not you have this evidently this really great depth of understanding of what you do, and you're a really good storyteller.
Thank you.
You're a really good
lot.
storyteller of like taking stuff that has a lot of depth to it and then synthesizing it into things that are concrete and actionable and understandable. And
thank you.
And I find that, at least for me, that is just like the hallmark sign of mastery of a subject matter. And so I wanted to highlight that and just thank you so much for today. It's been super fun getting to know you with your love of cheese and your obsession with hinging and all of those things.
The complex girl, you know?
Very complex. Yeah, you got 2 layers. That's it, right?
2 layers.
Yeah. Cheese, hinges, neuroscience.
I am who I am, you know?
That's it. Yeah. But no, it's been really fun getting to know who you are behind the professional, which for us is always, I mean, that's actually why Ryan tabled the idea and the importance of doing a rapid fire section. It's just like, listen, what are ways that we can kind of just talk about who people are as a person, and fundamentally today,
get people to take their glasses off because they're nervous.
They're sweating.
I'm sweating. Yeah, I can talk about mechanisms of neuroscience all day.
Yeah,
but ask me rapid fire questions, and I'm like, oh my god, what?
Yeah, I got one more rapid fire question for you. What's your favorite kind of cheese?
Oh God. See, this is an impossibility for me to answer in one way because it depends on the mood, the season. I mean, I just can't. I just simply cannot.
No?
Simply cannot.
Okay.
I like them all. I haven't really met a cheese I don't like. I'm going to be honest.
For me, it's a really good quality Gruyere in Switzerland. Ooh. Just like take my money. Anyways.
If I could say that, I would also agree. Yes.
No, you can't say Gruyere. No, Gruyere.
Yeah, that's how I say it. And I'm not gonna immortalize this on the internet by saying it. So
I'm going to offer this story because I think I'm on the opposite end of the spectrum. I do all the grocery shopping and I coach my fiance, and literally part of her meal plan is she gets 45 grams of cheese at the end of the day. That was like a prerequisite.
That's beautiful.
So she ate the rest of her cheese the other day, and she had asked me to pick. So she texted me her grocery list. It says cheese. Picked up the same cheese that I normally do, which is apparently the wrong cheese. And she was like, you didn't know that there was a difference? I was like, there's white cheese, orange cheese, yellow cheese, and then the cheese that's got some spicy stuff in it. That's all I know.
Get out.
Yeah. Wrong podcast.
So that's hilarious that's hilarious that you bring that up. So my fiance also does all the grocery shopping. So I'll text him my list and I will just say fun cheese, which means he has to somehow figure out what type of fun cheese that means. And this is like a point of contention in our household. And so that makes me so happy. Like I feel very heard and understood and validated because I do the exact same thing.
I can only imagine how much he's sweating when he sees fun cheese and he's just like, fuck.
He better pick the right one. It's
what do I do?
Serious.
You know?
Yeah.
He just drives out to a beach and just stares out.
Exactly. That is so funny. Man. Yeah, that's a little bit of a glimmer into our household.
I love it. And so with regards to your course of training as healthcare, from what I saw online, I believe you have some course dates coming up in the States. I'd love for you to plug
Yes.
those because that program sounds exceptional. And then
Yes.
I'm curious whether or not you have any dates planned for Canada in 2026 or 2027. Are there any plans for that?
I actually just talked to somebody in Ontario. I couldn't tell you the exact region, so I understand that's just saying a word, and a lot of spaces fall within that category. But I did talk to somebody that I'm trying to do some Canadian dates in 2027, actually.
Okay.
But yes, starting in August is when kind of my education schedule ramps up the second half of the year. So I will be in San Diego, Denver, San Francisco, Miami as well. And I'm probably going to get a New York date in the mix as well for training as healthcare. It's a weekend seminar that's for trainers, coaches, rehab providers, and students who are kind of interested in like bridging the gap and blurring the lines a bit more between the two, how to identify red flags, how to use training principles in rehab so we can level up rehab providers, as well as learn things that are totally within training scope of practice to manage pain too. So it's a kind of a full body approach, like very pattern recognition driven as well. So actually a lot of the things that we talked about today are units and sections within that course. So those dates will be coming up starting in August. Tickets aren't live just yet, but people can head to my Instagram or our Old Bull Instagram and see all of those dates.
I love it. Yeah, and we'll definitely link the website as well as your Instagram page in the show notes so people can check that out. I'm also, researching you and having the chance to chat today. I'm 100% going to be going to that course, whether it be, at some point in 2026 or 2027. And I'm happy to hear that you're looking to host more things in Canada. And so if you would like help with that, of course, like we're a relatively young educational initiative, but I would love to, the doors that we have open to us to leverage that as a means of getting you in, because let's just be real, like even like the best rehab practitioners in the world, like they know where their gaps are, and I think we need to work together towards improving the standard of care in the fitness industry. So I know I speak for myself, I speak for Ryan, that we'll do anything we can to help you kind of like get a foothold in Canada as much as possible. So
thank you.
Let's keep the conversation open in that regard.
Yeah, that means a lot. I'd love to. Thank you so much, guys.
Oh, it's a pleasure. And yeah, hopefully this won't be the last time that we chat. Once again, like, thank you so much for today. It's truly been a treat getting to know you and learning from you today. Ryan, is there anything that you wanted to mention before we close?
No, that was a blast. I appreciate you coming on.
Yeah, thanks, guys. It was a lot of fun. Would love to come back. So you say the word.
Yes. Excellent. Part 2. Stay tuned.